Coming up on the Doctor's Hospital podcast.
I think that what we have as a population is a high incidence and prevalence of metabolic disease.
Like hypertension, it's a silent killer. You don't know you would have it unless you check for it. So our annual exams usually do a basic blood test, urine test, and we go from there.
At Doctor's Hospital, our lamp just got brighter. The Loyalty Advantage membership program now has 3 unique plans to choose from. From Lamp Prepaid with free prime care visits and service line discounts, Lamp Insured with copay waivers and 0 upfront collections at the ER and inpatient services, or our new Lamp Access, a free plan that offers 10% off labs, pharmacy, and imaging. Lamp has a plan for everyone. To sign up, visit our website or give us a call. Doctor's Hospital, trusted and best care now.
Welcome to the Doctor's Hospital podcast. I'm your host, Alexis Burrows, Marketing Director at Doctor's Hospital. I am excited today. We are joined by 2 physicians. I think this is our first 2-physician pod since we've restarted the podcast this year. And we are here to talk about all things related to kidney awareness and nephrology. I'm joined by 2 internal medicine and nephrology consultants. First, Dr. Frederick Smith, who is the Clinical Director of Nephrology here at Doctor's Hospital Health System, as well as Dr. Monique Pratt, who is the Medical Director of Dialysis Services for Doctor's Hospital Grand Bahama. Welcome. I welcome you both to the show.
Thanks very much for having us.
All right, so we are celebrating in the month of March Kidney Awareness Month, which is why we have you here today to kind of talk through some of the information around kidney health, screening, diagnosis, treatment, kind of the whole nine. But I like to start off the podcast by getting some background information, because I think it's interesting to navigate and understand how people kind of got to particular places in their career. So I want to ask you both, what got you interested in medicine generally, but more specifically in taking the path down nephrology? So we'll start with Dr. Pratt and then we go to Dr. Smith.
All right, thanks. That's actually an interesting question, because lots of people ask me that question, like, how do you get involved in kidneys? Because it's such a small organ, it's very specific, and it's very involved. Well, I'll go back to when I was training in residency in New Jersey, and we have rotations that we do a few weeks in each area. And one of my internal medicine attendings, he was a nephrologist, and he was on my service for a month. And that's when I learned about nephrology. I had a really good time with him, learned a lot about the kidneys. I also did a 2-week rotation in my 4th year with a nephrology consultant in the office practice. And the reason why I got to love it is that I always want to make a difference in my race. I mean, it sounds like it's prejudice, but it's not actually. But I know in the Bahamas, growing up, we have a lot of hypertension, a lot of diabetes, and kidney failure. Most of the main causes of that is hypertension and diabetes. So I really wanted to, knowing I would probably come home at some point, I really wanted to make an impact, even when I was in the U.S., on the minority race, which is being able to intervene from them getting kidney problems. And I loved hypertension, the research hypertension for many years. But that's the main reason why I got involved, just to make a difference in our particular race. Yeah, that's what I want to.
And it is an issue, obviously, we're predominantly Black community here in the Bahamas, but obviously coming back home to help your people, because it does have a high prevalence in our society. Dr. Smith, what about you?
I think it goes back to some of the similar things that Dr. Pratt spoke about, where we have had mentors in our lives that have been interested in the environment or that some specialty, so it got us there. And forgive me for calling names, but I think about people like Adrian Soy, I think of Ada Thompson, I think of Ilsa Grant Taylor, I think of Ronnie Knowles. And if I go back to my Jamaican experience, I think about Everett Barton. But what they did is they all gave me different components of what internal medicine and nephrology would be about. Some gave me a little bit more of an academic experience. Some gave me more of the interventional experience. Some gave me more of the social component of it. And then when I took all of those and put them together, I said, if I could take all of them and bundle them into one, that's what I want to be. That's what I want to be.
That's awesome.
So I think that's where it is.
Yeah, and I think, we've had a number of physicians on now in this past month leading up to this conversation today. And I find it interesting how a lot of it does tie into that residency and that experience in training and getting exposure to different things. I think Dr. James mentioned the same thing. He did some time with a cardiothoracic surgeon, and it's kind of what led him in that direction. So I do find it interesting that seems to be a recurring theme with the physicians, that a lot of time comes out of specific experiences within your training that kind of leads you to say, you know what, I like this. I can see myself doing this, and I can see myself having an impact, like Dr. Pratt said, in this particular way. So, kind of moving more into what it looks like when you get into actually treating conditions. What would you say are the most common kidney conditions that you see popping up most often in your line of work? So you start with you, Dr. Smith, and then Dr. Pratt.
Okay. And I'm sure Dr. Pratt would have answered this better because she's all into the research even more than I am.
Okay,
but
fair enough.
But if I could use personal experience in the units that I've been involved in, I think we're mirroring what the U.S. data says.
Mm-hmm.
U.S. data says that it's hypertension, diabetes, and it flip-flops. Some people say diabetes, then hypertension. But I think that is the predominant thing. And then added on top of that, I think that what we have as a population is a high incidence and prevalence of metabolic disease, i.e. obesity.
Mm-hmm.
And with obesity or the metabolic syndrome, the diabetes and hypertension, there is a good subset of patients, or a large subset of patients with renal disease. And then if we add on top of that, we have to remember the non-communicable diseases as well. The bads, the other things like the bad infections.
Mm-hmm.
And then after that, we start going on to collagen vascular diseases, lupus in our population. And even obstruction, because, as men, we don't like to go to doctors. So that whole thing with prostate cancer and that sort of thing, it becomes a real tug in our population.
It's quite a laundry list.
Mm-hmm. It is.
Dr. Pratt, can you add to that?
Yes, I'll echo the same sentiments Dr. Smith said. I see similar things in Grand Bahama and also in the United States, in the Caribbean. We see here hypertension, the diabetes, and our population, the lupus, obesity-associated glomerulopathy, which is similar to getting end-stage kidney disease from being obese. I also want to add also, which is a newish entity, was when COVID came into play. So we can't forget COVID. We see the lupus, of course, as well, but we cannot forget COVID. COVID actually was new for all of us, whether it's infectious disease, internists, surgeons, nephrologists especially, because COVID actually ended up causing kidney failure in a lot of patients. So we saw a surge in that, and we tried to figure out what was going on. And as research went on, time went on, and in retrospect, they looked and said that the COVID virus actually affected the kidneys. They would get acute kidney injury from being dehydrated, or they would get affected by the virus itself, which caused kidney damage. We saw lots of it. And Doctors Hospital played a big role, of course, as you know, in that pandemic. So we cannot forget the COVID as well as other infections, but as the most popular ones, hypertension, diabetes, flip-flops, both here and pretty much worldwide.
Right.
You have the other diseases like diseases in kidney and for the kidney in children, but which is more rare, but we see some of those. I saw a couple of those where they end up growing out of it. Some may require dialysis, some may not, just require some steroids. Then, of course, the lupus is popular. I see some rhabdomyolysis, muscle breakdown from working out or from COVID as well, other issues that can cause. You have kidney stones, as we mentioned, blockage, obstruction from prostate or from kidney stones can cause an acute form of kidney issue. So we see a variety of those things. The majority, hypertension and diabetes, the lupus, the obesity, and then I would say COVIDs, and then other things following. But that's what we see, kind of a span of our practice.
Okay.
And forgive me for adding one more. Medication.
Right. Oh, let's mention medication. Let's speak about medications and drug-induced nephritis, and also herbal nephropathy too, weight loss drugs. Taking too much of NSAIDs, non-steroidals, like too much Aleve and too much Advils, they can get them causing kidney failure as well.
Because all of that processes through the kidney. And
yes, exactly.
Then you have
that's the thing.
That challenge,
yes, and causes direct damage actually. Yeah.
So does that mean, I just kind of sticking a pin on the COVID point, so is that something where as we go into the future, people who've had COVID, even if it hasn't popped up yet, does that become a risk factor if you've had COVID for potentially developing renal disease?
Not necessarily.
Okay.
Not everybody gets COVID-associated nephropathy, called a COVAN. It's in select. Patients have, it depends on your comorbidities, it depends upon your basic kidney function. Some patients just got it from getting rhabdomyolysis. Right. So there's no rhyme or reason why someone can get it, and doesn't increase your risk of getting it, having COVID before.
Yeah, no, it's good to know, because sometimes, people hear that and they go, oh my God, I had COVID. Like,
at least in the research, I didn't see that.
Right, okay.
So,
no, but that's good to know.
So can I stick a pin? So, and I'm not going to say directly COVID, but I'm going to talk about other things as well. So they have this whole thing, what they call a two-hit hypothesis, that if you've had kidney disease once, the second time, or then something else hits, it makes it even a little worse.
Mm-hmm.
So whether it's COVID, and a whole lot we don't know about it
Right.
still.
Right.
But I think that it's the COVID plus that does it. The COVID
Right.
plus the diabetes, the COVID plus the hypertension.
Right.
So I think that was just worth saying.
Okay,
Right.
No, understood. So sticking with you, Dr. Smith, then, when it comes to, diagnosing and figuring out what's happening with somebody's kidneys, how do you usually go about that? And then, what is your game plan for treating it, depending on, I guess, on what you find?
So I guess very interesting question. You're taking me back to medical school. Because typically what we do is the same thing that we do for everything else.
Mm-hmm.
It becomes a history. We take it and find out what the patient complains or what their signs and symptoms are. And then we go into basic investigations and more specific investigations. So typically what we really do need is a blood test, a urine test,
Mm-hmm.
and then plus or minus some imaging.
Okay.
So we go about that from that standpoint. And that's why, truthfully, like hypertension, you don't know that you have it until you go looking for it.
Mm-hmm.
So that's one thing. And then I think the game plan for me is, it goes back to the old adage, it takes a village to raise a child.
Mm-hmm.
And the old adage for me is it takes the entire healthcare team to take care of a patient. So it goes back to me for the primary care.
Mm-hmm.
It goes back to, if you're talking about nephrology, it goes back to the nephrologist, it goes back to the nephrology nurse, and we have nephrology nurses. It goes back to all of the ancillary staff that are there, the dietitians. So for me, again, it goes back to you because you're responsible for airing us for education.
Right.
So it goes back to the educators, the counselors. It goes back to the entire team to make one person better.
Yeah, I think that's something that we've been seeing consistently as well. There's been so much conversation and discussion around the critical importance of a multidisciplinary approach to healthcare. We've seen that pop up in a number of our conversations. And I think just in the general broader discussion around healthcare, the need for having individuals from different disciplines, even with just different areas of care, like you said, the nurses, the entire team working together to bring about the best possible results for patients. So, Dr. Pratt, technology advancements is always something that I imagine you're looking at to say, how can we take a step forward in the way we diagnose or the way we treat? So from your perspective, what recent breakthroughs in technology or advancements in technology, whether in the treatment or the diagnosis of kidney disease, get you excited about the future of the field?
Well, I think I would say the most important thing right now, especially for the Bahamas, that has me excited, is unlike other countries, Caribbean countries, and unlike the United States, where they do have kidney transplant as a form of renal replacement therapy. We had it in the past, in distant past. Dr. Robin Roberts did a few back then, but knowing that right now we're on the helm of doing that, not just in the private sector, but the public sector, since we have so many patients that need it or can benefit from it. So I think that's what has me most excited about. That could be a major breakthrough in the Bahamas for us.
Right.
As far as medications, on the rise, well, I'm about to attend a conference, hopefully this year, see if there's anything new. They have new medications here and there, nothing really major. Dialysis has always been around for centuries. It's still around. We have different types. We have peritoneal dialysis, which we have a few patients on here in Nassau, not in Grand Bahama. We have them here in Nassau. We have many patients on dialysis. Some patients do home hemodialysis, which is a little bit more intricate, and we have challenges with doing that in the Bahamas because of the type of equipment you would need for that, and it's kind of difficult with, I think, the company that makes it. I think they don't get it to the country as much as we would like. So it'd be difficult to do home HD, where a patient can do it themselves. It's a small machine. They use cartridges to do it every day.
Right.
So if we can get that on board, that's going to be another thing I can look forward to in the future to work on that. But the other forms of modalities, we have medications. We pretty much have all the cutting edge medications. To be honest, nothing major as far as medication wise on the cutting edge of nephrology to prevent, I would say prevent, to say treat dialysis patients with. We have the same medicines for a while, different formulations, maybe they make them better, but the overall treatment for them has pretty much been the same. So we're hoping some new things will come out. The main thing I'm excited about mainly is the transplant that we can get. And hopefully we can do home home hemodialysis at some point for the patients, which means use their home dialysis machines versus the PD.
Next
so
stage.
Those are the next stage. Right? It's called next stage. And it's a very low fancy machine, but it's specific to the company. So we've worked on maybe able to get it here. That'll be another thing. So transplant and next stage home hemodialysis is the two most exciting things I think I'm looking forward to.
And I know we're going to cover a little bit more in terms of the reemergence of transplant locally.
Yes.
Especially over the next few weeks. Obviously, this is something that, us here at Doctors Hospital, we're very excited about trying to re-engage in that space because, like you said, we do have a number of patients that exist that are in need of transplant, and if that's a service that we can begin to offer locally, that greatly, I imagine, increases the chances of people living longer, being able to have longer life and being able to enjoy their families and all of those sorts of things for a longer time. So going back to you, Dr. Smith, lifestyle has been a recurring part of our medical conversations as of late, no matter who we've spoken with. So how do things like diet and exercise play into kidney health? And then, if you do end up having the disease, how does it play into managing kidney disease?
Okay. So, me always just going back to what I want to say as opposed to what you've asked me. So, I just have to go back to what Dr. Pratt was talking about. Dr. Pratt, I am so excited about transplant.
Yes, me too. Sure.
I'm so excited about transplant. I'm excited about our recent hero because that's the term that we want to use, our hero.
Yes.
And I am so excited about our honor, our walk of honor. That was just fabulous. So to our hero and our hero's family, God bless you. It's a gift of life. That's exactly what it is. So going back to what you're saying with lifestyle, I think it goes back to some basic tenets of life or of growing up, so to speak. So pretty much we were almost forced to eat everything that was on our plate, and they gave us lots on our plate. And if you happen to be the boy in the house or the male in the house versus the female, even more, right? Have everything on the plate. And it was supposed to be a mark of honor, right? But truthfully, what we really need to do is, from basics, I think that what we need to do is try to curb childhood obesity. If we could stop thinking that the big baby is the healthy baby and start to coin it a little different, the baby that is on that 90 to 100 percentile on terms of the weight is probably the risk of the obese baby, then maybe we would get a whole things changed from younger on, because I think that's where we need to start. And I think that what's everybody's talking about, starting from the younger age, giving them better food choices from then, creating a healthier lifestyle from then. I think I saw something on the internet the other day and talking about the babies that are raised with the iPads. We give them the iPads so we could get them quiet, and it gives us some time to do the things that we want to do. But reality, we're raising them on iPads as opposed to outside and exercising. So we are doing our children a disservice, even though we think that we're probably doing them an advantage or something.
You get them into that sedentary lifestyle very, very early on. I guess it's interesting when you talk in that space, the phrase that an ounce of prevention is worth a pound of cure. And if you apply that, kind of to the logic that you're talking about, it's why it would make sense to try and curb it from the childhood, because you start off at a disadvantage if you have childhood obesity, because then you're fighting that fight from day one, essentially. Whereas and a lot of that is influenced by the people around you, not necessarily your own personal choices as a kid. So that does kind of it moves into that same idea of an ounce of prevention being worth a pound of cure. Great conversation thus far. We need to take a quick break. We'll be right back talking with Dr. Smith and Dr. Pratt about Kidney Awareness Month right after we have some words from our sponsors.
March is National Kidney Month, and Doctors Hospital is celebrating with a special offer just for you. For the entire month, we're offering 50% off kidney health screens. Take charge of your health and secure your future by booking your appointment today at clinics.doctorshosp.com. At Doctors Hospital, we prioritize your health, providing trusted and best care now.
All right, so let's go back to you, Dr. Pratt. Obviously, again, we were talking earlier about an ounce of prevention being worth a pound of cure. So that leads right into my next question, which is, catching kidney issues early sounds very important. So can you kind of talk about why it's critical to be able to determine early on if somebody has an issue with their kidney?
Correct. Just like any other ailment, whether it's cancer, any type of communicable disease, prostate, you get it checked early so you can intervene. Similar with kidneys. The earlier you get it checked out, which means just getting your basic blood test and urine test, the quicker we can intervene, which means that we can slow down disease progression if you have kidney disease, and we know how to prevent it if you do not have it. So it boils down to you just getting your regular physical exam, your regular chemistry, your regular urine test. If we see something wrong, we look at the BUN or the creatinine. The kidney clears these particular toxins that we look at. So if it's normal, and we'll say, okay, change lifestyle, if you see a little mild disease, so we can intervene early and prevent you from getting on dialysis or needing to get a transplant. And that's why it's so important. Like any other disease, like breast cancer, prostate cancer, colon cancer, screening, early detection, same way that we can prevent things from getting worse.
Right. And so it sounds like from what you're saying, the screening process for this is typically captured within someone's standard annual physical
exam, because like hypertension, it's a silent killer. You don't know you would have it unless you check for it. So our annual exams, usually Dr. Smith mentioned, we just do a basic blood test, urine test, and we go from there. Okay. And it's very simple, just your annual physical exam.
And does that frequency change depending on if you find something, even if it's like in the early stages or pre, like how people talk about pre-diabetes, is it something where that frequency where you need to get it done more often?
Yes, it does change. Usually if someone has mild kidney disease, we'll watch it get blood, say every 4 months. But if you have more severe, we check them usually every month.
Okay.
Blood and urine, and in the office visits every month if they're like more stage 5. There's 5 stages. Stage 1 is mild. Stage 5 is severe kidney disease where you almost pretty much need dialysis. So stage 3 is kind of in the middle. Right. So when you hit like stage 3, tend to monitor you much, much closer.
Right.
Definitely 3 months. I see them in office. I don't know if Dr. Smith does the same thing. Every 3 months. We check the blood work, the urine test. We can see something's wrong, check the medications, adjust the medicines or diet, depending on what we see. So you want to prevent disease progression. That's what we look for. So we tend to monitor them more frequently the more severe your disease is.
Understood. Dr. Smith, for people who are dealing with chronic kidney issues or full-blown kidney failure, how do you lend them support? And so that's both as a physician, as a system, as an industry. What does that look like?
So I can put on my very doctor's hospital health system cap. And in putting on that cap, I think that there are multiple things that we do in our institution. And I think that it happens more for the end stage renal disease or the stage 5 that Dr. Pratt spoke about more than it happens for the ones that are above that, those 3 Bs and above. So I know that in the stage 5, when we have patients on dialysis, there is the patient relations officers that can get involved with some sort of assistance with them up and about if they're in the institution itself. If you're talking about outside of that, we do have dietitians that assist with us. We have a psychologist or somebody that does counseling at the hospital. And there is absolutely no way that we cannot talk about the dietitians and the nurses that do a whole lot of assistance and trust. The nurses just don't do the dialysis for the patients. They get involved in their family affairs. They call them up to see how they're doing, how they're not doing. They give them advice. They do tons of teaching whilst they're there. So I give a little shout out to my nursing team led by Natasha Mitchell at Doctor's Hospital. And this is Nassau. And who's it again in Freeport?
It's Rochelle Lewis.
And Rochelle Lewis in Freeport. So we have to give shout out to them. And then in people that are non-dialysis, we have what they call CRIC clinics, chronic renal insufficiency clinics.
Okay.
And then what we do in that is physician plus or minus nursing staff, and depending what's available in your office, we offer them more support. We try to get families involved because we know that the families are also the heroes in this regard. And I think nationally or in society, I'm not sure what they have in Freeport, Dr. Pratt, but I know they have the Kidney Foundation here. I know the Kidney Foundation is doing a whole lot in terms of assistance.
We do the same thing.
And Kidney Foundation.
Yeah.
So again, a multidisciplinary and truth, education, talking to people at their churches and social groups. I think that does wonders as well.
Awesome. I think it's critical that you mentioned social support and the engagement that the nursing staff in particular has with families and things like that. Because I imagine, especially for patients who get into later stages of the disease, having support from their families, even in managing, I imagine as your diet needs to change in order to manage treatment and things like that, having the buy-in and the support of the family system or the friend network of that particular patient is critical.
Because they should have one pot in the home.
Right.
And if you have to change your diet for renal disease, it means that your entire family should be changing theirs as well, because that's the support that you get. One pot in the home. Stop cooking these 4 and 5 pots for different people.
I'm surprised we got this far on the podcast, especially considering we talked about lifestyle and I think we've had a couple of conversations in the past.
Absolutely.
You always like to talk about the two meats on the plate for Sunday dinner. I'm surprised we got this far without having that particular comment.
That still happens.
But
you could do 2 meats. You could do chicken and fish. So I don't know what.
And small amounts.
Small amounts.
The palm of your hand, right?
The palm of your hand.
Yes, proteins.
All right. So, Dr. Pratt, I think we talked about this a little bit already, but just kind of, I guess, looping in a little bit to kind of close it off. When it comes to managing kidney conditions, where does medication fit into the framing of treatment?
So medications are very important. We have medications that diabetics, mainly hypertensives, anyone with kidney disease that can tolerate them, that needs to be on board. They're considered to be renal protective medications. These include the class of meds of drugs called the ACE inhibitors or the angiotensin receptor blockers. So those are very critical to us as far as nephrologists, but having patients on them, not just to control blood pressure, but they'll protect the kidneys. They kind of help heal the kidneys a little bit, prevent progression of whatever may be going on in the kidneys. So they're very, very good drugs that we'd like all of our patients to be on to a certain stage. Once who can tolerate them, don't get complications from them, we prefer to have all the patients on those particular drugs. Medications are very critical because of the surrounding of the whatever caused the kidney disease. We have to make sure we control that. So blood pressure is important to control with multiple medications most patients need. Diabetes needs to be well controlled with diabetes medications. So it's very, very important. Medications in general important in helping to prevent kidney disease progression or developing kidney disease.
Okay. I'm going to ask you both this question. I think you both kind of touched on it in a couple of different ways. I'll give you another opportunity just to kind of speak to it though. But it does seem like, and I think Dr. Smith, you mentioned this, or you may have both mentioned it specifically, that kidney health, in terms of diagnosis, treatment, the whole nine, is a team effort. So how do you work with other healthcare colleagues to give your patients the best care possible? So you can start with you, Dr. Pratt, and then we go to Dr. Smith.
I think the most important key is communication. And also because if a patient comes from the hospital into the dialysis center or from outside the dialysis unit from another facility, it's very important that we have close communication with our colleagues, whether it's nurses, whether it's the technicians, whether it's the clinical nurse managers, our social workers, our colleagues. Between Dr. Smith and I, we have co-managed a lot of patients together. I'll have a patient in Grand Bahama that needed a high level of care that I would transfer to him. I have a patient in Grand Bahama would need a kidney biopsy that I was sent to Doctor's Hospital to get a kidney biopsy. So communication and sharing of medical records are critical in the best care for the patient from my standpoint.
Okay.
And I'm going to make the very easy point about it. One day at a time, multiple conversations, never stop talking.
Right. Communication.
Awesome. I think that's framed perfectly. And then lastly, I want to end with this. I imagine as physicians who have been in the craft for a while, I'm not belying anybody's age, but I imagine you've encountered a number of different patients that may have had an impact on you, whether that's professionally or personally. So Dr. Pratt, starting with you, is there a particular patient story that you have where your interaction with them changed or impacted you, how you approach the field, or just made you better as a physician overall?
Yeah, this one particular patient, and Dr. Smith and I share this patient in common. It was a young lady. She was very sick. She was very young. She was actually a child. She was 15 or 16. And she was very ill. She came to me very ill and had some kidney disease related to when she was a child. So I did the best I can with working her up. And I said, okay, I knew she needed a biopsy right away. Tried some treatments in Freeport. She's getting a little ill. So I called Dr. Smith. I said, look, I have this patient here. I have her parents. We got to get her to Nassau. She was challenging for both of us. Got her to Doctor's Hospital. Dr. Smith, got everybody on board, pediatrics, Dr. Smith. And she was so tough. She ended up on a respirator and very sick. I said, Dr. Smith, we got to get her out.
Absolutely.
We agreed. And we had to actually transport her to Children's Hospital in Miami at
Mhm.
Holt. She ended up being, I think, one of their research cases,
Mhm.
and they agreed with what we did so far. They loved our care with her,
Mhm.
but she was just that level of illness
Mhm.
and complications. Long story short, now she goes to my church, of course. She is the most beautiful girl. She's doing so well.
Amazing.
I just saw her
Amazing.
last week.
Awesome.
And her mom, actually, they're parishioners together, but they're also very close friends of mine.
Mhm.
And she's very dear to me. I was asking her, how's the baby? I call her the baby. How's the baby doing?
Mhm.
Because she was literally a baby. She was 15.
Mhm.
Very, very ill. And now she's a beautiful young lady getting ready to go to college. And
That's awesome.
she's incredible. I just saw her last week at church.
That's
So
what you
she's
call a
doing very well.
miracle, eh?
Yes, but it was a really
Yes,
miracle.
yes.
She was short of a
Wow.
miracle.
A miracle.
And we know what it was just very, very ill young lady.
Mhm.
And she came out and tolerated treatment like a champ.
Mhm.
And she looks well. I don't even see her, which I'm fine saying, I don't mind if I don't see you, which is good news. She calls me once in a while to get some medicines or whatever, but she's doing that great.
Awesome.
From being that, yes. That's one of my best stories I could mention that had an impact on me and her family.
Right.
Mhm.
That's amazing.
Listen, I could go with Dr. Pratt.
Yes, she
I
really
go with
remembers the
Dr.
story.
Pratt.
Yes,
I
she
go with
picked both
Dr.
of our
Pratt.
brains.
Yeah, she
It
showed
was,
it.
yeah, we talked about her. We had everybody involved,
Mhm.
dealt with her multiple times a day. I mean,
Yes.
our brain cells were on like overload.
Mhm.
But we did the best we could. And we did our best, as they mentioned in the States
Right.
we did. But she was very sick. Mhm.
Yeah, but I mean, it speaks to the team approach, right?
Yes.
Even when I guess amongst nephrologists who are working together to bring about the best possible
And other
outcome
disciplines
care.
too were
Right.
involved with her.
Right.
Rheumatology and
Mhm.
other disciplines, pediatrics.
Awesome. This has been a great conversation. I want to thank you both for joining us on the podcast. I will allow you to just kind of plug quickly. If someone is in need of having a visit with you, either of you, how do they go about making that appointment? I know it's sometimes a referral-based service, but how does that work? How would people be able to get in contact with both of you if they were in need of care?
Here in Grand Bahama, we're all this is on the website, Doctor's
Mhm.
Hospital Health System website,
Mhm.
as you can just choose whatever aisle you want to go to, a specialist you want to see.
Mhm.
Pretty much the only one right now at Doctor's Hospital in Grand Bahama
Right.
under our system, health system as a nephrologist
Mhm.
or an internist. You can multiple, but you can see me at internal medicine nephrology.
Mhm.
And you can just call the office 350-4490.
Mhm.
And I have office hours Mondays and Wednesdays from 9 a.m. until 4 for internal medicine issues, nephrology issues. And that's where I can be found.
Awesome.
And I will echo the same sentiments.
Mhm.
I'm available through Doctor's Hospital Health System. I'm also in the private arena. And then I'll also say through Centerville Medical Center, which is again Doctor's Hospital. And for a plug out for our clinic in our Eagle system in Exuma,
Mhm.
then we can start talking about having visits in Exuma if you'd so desire.
Yes.
Awesome. Sounds good. So again, I want to thank you both for taking time out of your busy schedules to be here and have this conversation. I hope that it's a very interesting and eye-opening one for our listeners. So thank you both.
Thank you.
Thank you. Thank you
All
for
right.
having us.
Awesome. So to our listening audience, thank you for listening to us today on the Doctor's Hospital podcast. As always, we invite you to like, comment, subscribe, and share, and we'll see you here next week.
Doctors Hospital is Reimagine Primary Care. We have invested to improve our health system, ensuring that accessible, affordable, world-class clinical care is closer to you. Your relationship with a primary care provider shapes the foundation of your overall health. Our new, modern primary care facilities are where critical diagnosis and true personalized treatment begin. With locations across New Providence, Grand Bahama, and Exuma, we invite you to experience the Doctors Hospital difference. Book your next appointment at clinics.doctorshos.com.